Good evening, everybody. Thank you for that introduction. Hopefully you can all hear me okay. I won't introduce ourselves again. Carl and I are working here at the Royal Sussex County Hospital, the only major trauma centre with a view of the sea. Currently, it looks like a bit of a building site, unfortunately, but that is the future. So I have a lot of trainees with me, and the feedback from the exam is I get the questions that people are asked every sitting, and still common things are common, and supracondylar fractures tend to be asked to almost everyone. So most of the talk side of this evening, I'm going to go through supracondylar fractures. My aims of this are to give you a plan, because I think the paediatric part of this Viva is a place where you should be aiming to get an 8. There's a limited number of things people will ask you about, and very clear plans and guidelines that you can follow to really sort of impress the examiner. Will come up in the Vivas, and we can discuss that then. But I want to get across in the sort of 15 minutes I've got things that tend to trip people up regularly in the feedback I get from the exams. So the aims of this session are to give you a plan for theatre for when you're asked, a brief discussion about lateral versus crossed K-wires, so you can decide, and then what will always come up in the exam is the pink pulseless hand. And I'm going to give you one safe, effective way of managing that, guidelines, my experience, and a bit of an evidence review. There is a health warning with this. There's no incontrovertible evidence, and everyone has their own opinion. But what you want in the exam is a clear, effective way of answering it. So that's what this session is about. So we're not really talking about this. This may not project perfectly on your computers, but that's a sort of Gartland 1 undisplaced fracture. I couldn't really care if you treat that in a sling or a plaster. All will do fine. You're not really going to get that in the exam. Again, not really contentious is your sort of Gartland 2 supracondylar fracture. We can discuss that in the Viva. Beware though, if you're going to be shown a picture in the exam of a apparently simple fracture. Excuse me with my video, my kids after. Just beware if you have an exam in the wrist, or you can see the wrist on the X-ray, because as we'll see from the Vivas, the question can go in a slightly different direction, but otherwise you'd manage that as with any supracondylar fracture. What I want to spend a bit of time on is your plan for this, because this is what you're going to get in the exam. It's pretty much always going to be 8 or 9 p.m. at night when this child comes into your examination or into your hospital, and pretty much if the limb is ischemic, then that's an easy answer for you. Or if the limb is completely well perfused with a good pulse, that's an easy answer as well. So we're going to spend a bit of time talking about the pink pulseless hand. So when asked this in the exam, you just want a clear, guideline-based, sensible approach to doing it. So you're going to document a neurovascular assessment. You're going to talk about the setup in theatre, which I've got a slide for later on, where to put the image intensifier to make it sound like you've done this many times before. You can say whether you want an assistant or not. I'd suggest being able to do it solo in theatre. An old boss of mine used to say, you know, the reduction maneuver, slight flexion and traction for the whole of the stairway to heaven, depending on where you live. It's just for a long time, you know, letting the muscles relax to allow you to do that. And as I said, we're going to talk about K-wire configuration. You need to be aware of the BOST guidelines for supracondylar fractures. They are guidelines, but they're pretty clear about having to have a documented assessment of limb perfusion, both pre and post-op. If the limb remains ischemic, there's no timelines given, but if after your open or closed reduction, exploration of the brachial artery is required. And on that note, in the Viva, you need to have an idea of how you're going to approach your open reduction. Again, doesn't really matter. It's opinion based whether it's laterally, medially or anteriorly, but you've got to have a plan. And again, we can discuss that in some of the Viva cases. The BOST guidelines say nighttime operating is not necessary unless urgent indication for surgery. Doesn't really give absolutes, but again, we can discuss that in a bit. And it also says if a medial wire is used, a technique should be used to avoid injury to the ulnar nerve. If you look at the American guidelines, actually, and the American Academy of Orthopedic Surgeons, they just recommend lateral wires, and we'll go into a bit of that later. They also say 2 mm wires should be used where possible. Just beware with the very young children. If you're seeing an X-ray of a, it might be unusual, but a very young child, then you probably wouldn't jump in straight to saying 2 mm wires, because it just doesn't sound like you've hung around the children's theatres too much. So we use a Proforma because we found that however much we tried to persuade registrars to document clearly about the neurovascular status, it never happened. Now we've introduced this pre and post-op, or I should say Carl James introduced this pre and post-op, that our documentation has become much better. My recommendation for both for life actually in general, but also for the exam, is to set up for supracondylar fractures like this. And certainly for the off-ended supracondylars or the flexion type injuries, if you have your C-arm parallel to the table and the patient, it allows you to swing through for a lateral without having to flex up the elbow. And for the particularly unstable injuries that you're struggling with, that can make a world of difference. And saying something like that in the exam, together with the other things you're saying, will give you will certainly give you a head start in aiming towards your 8. So for the pink and pulseless hand, you can always find evidence to take you down either track, to be honest. These are slightly old papers, but they're still useful. So the BOST guidelines are based on some of this, as in whether you wait less than 8 hours or more than 8 hours. This is with Gartland, off-ended supracondylar fractures with a pink pulseless hand. There wasn't shown to be any adverse outcome from waiting till the next morning. So in your exam, you can go down the BOST guidelines route and say they'll be first on the list the next morning, depending on the time of day. Also, other papers have shown some quite significant vascular injuries with if the pulse doesn't return. So I think you're always on good ground, depending on the time of night we're talking about, to just say if you're competent and confident to just go to theatre within reason, sort of almost any time of night. So don't be pushed down one route or other. AOS guidelines say in the absence of any reliable evidence, open exploration of the antecubital fossa should be performed in patients who have a pink pulseless hand after reduction and pinning. Again, they don't give any timeline on that. You might want to use a Doppler, or obviously wait for things to warm up and wait a few minutes before diving into the antecubital fossa, but it's certainly something to be aware of. So again, people have different ideas of, different surgeons will have different ideas of what is in their practice. But I'd suggest in the exam just having a definitive idea of how you're going to treat it, and you can back that up with evidence. Now, I've barely put a medial wire in years because of papers like this. So someone is injuring ulnar nerves. Obviously, we're all the best surgeons in the world, so it's never us. But I think this is enough reason to try and treat supracondylar fractures with lateral wires. And if done well, there's no clinical difference in the outcome. Only a sort of theoretical mechanical difference in the fixation. So being aware of papers like that to back yourself up when you're in the exam can be very useful. So just a slight technical point, I think it's very useful to try and visualize what you're trying to do when you're doing 2 lateral wires, and get 2 wires crossing the fracture site in either half of the humerus. Obviously, there's no concerns about crossing the capitellum or the olecranon fossa. as long as you've got that decent spread at the fracture site, you'll have a good outcome. And you can always use a third wire if you don't have the stability you desire. So the reason I set up all supracondylar fractures in the same way with the C-arm along parallel to the bed, just so the theatre staff and everyone working with me gets used to it. And I think that's a reasonable thing to do, because particularly if you're presented with something like this in the exam, a flexion type supracondylar fracture, you want to just show that you're aware of the difficulty with reduction and pinning of these sort of fractures, and just mentioning that you've set the patient up like that so you're able to swing through for a lateral without having to mess around positioning the arm would just fill me with confidence if I was sat opposite you on that exam table, to show me that you've been there and done it. They're obviously pretty rare, but it's just useful. And some of the very unstable extension type fractures as well, it's always very useful. So as I ask all our registrars, and you should talk about this in the exam as well, to assessment of stability after you've fixed the fracture, and get a view in external and internal rotation. And if that's still slightly unstable, you can put a third wire in. I understand that's not what everyone would do. You may put a medial wire in, and there's not a right or wrong there. It's about what you're used to doing and where you were trained. But it's perfectly reasonable to put a third wire in if that's what you're confident doing. They might then move on to ask you about the complications, and it's best to talk about the sort of malunion and deformity rather than a growth arrest in supracondylar fractures that gives us that common gunstock deformity. You need to be aware that that's mostly a cosmetic issue. If you're getting on to discussing that, you're doing incredibly well. And never forget the compartment syndrome with concurrent distal radius fractures. So that is my run through of supracondylar fractures. We're going to talk much more about the other injuries that come up commonly in upper limb trauma. I just think the best place to do that, to go through so many of them, is in the vivas that we'll be doing in a little while after Carl has had a chat to you. So thanks for listening. We're going to do questions at the end of Kyle's talk, Carl James, in just a sec. So if you've got any burning questions for the regarding supracondylar fractures, you'll have to wait just another few minutes. So thank you for listening.
So guys, we're going to try and go through some of the lower limb fractures and discuss some of the things you need to think about in a viva situation. And so it will help you to answer the question a bit better and try and flesh out some of the difficult controversies. So I'm going to talk about slipped epiphysis first, because this frequently comes up in a viva. The important thing is that we need to start talking about slipped epiphysis in terms of stable or unstable, Lotus classification, and the stability is stability for the child to weight bear. Now, stable slips, there isn't much controversy when we come to management of a stable slip. But you need to understand that treatment might change depending on the severity of the slip, how great the slip angle is. So mild slips, we measure as a less than 30 degrees or 1/3 slipping. We will pin in situ. A single in situ screw fixation is the accepted method of treatment, which has the best long-term follow-up. When you get onto a moderate slip between 30 and 60 degrees, unfortunately, this leaves a bump, which can lead to impingement later and develop arthritis at a later age. But still, the management of stable, moderate slips is still a fixation in situ with a single pin. Now, whether or not we go on to manage the bump later, either through arthroscopic or open means, is still debated. And we don't know if this changes the natural history of these slips. There's still some new methods using growing screws to see if the hip can remodel with growth, but we don't know whether or not this will be the answer. So all you need to know for a moderate slip, the child will have a bump which can lead to impingement and can cause arthritis or labral pathology in early adulthood. Now, severe slips we'll discuss a bit later on. Unstable slips are the biggest area of controversy. And for that reason, the management of unstable slips is trying to be centralized in the UK. So it tends to be managed mainly in pediatric centers because there's no consensus on when we should operate. Should it be immediate or should it be delayed after a period of traction? What's the best way of operating it on this hip? We don't know whether we should try the serendipitous close reduction, a mini open, or a formal open with a done procedure, or a surgical dislocation. What we do know is that unstable slips have a high rate of AVN, and even the rate of AVN differs throughout the series. The systematic review shows between 10 and 60%. So the AVN rate differs, and we don't know what causes AVN. Is it kinking or disruption of vessels at the time of the slip? Or is it pressure from the hemarthrosis in the hip, reducing the blood supply? So when we talk about AVN, you'll need to know about the deep branch of the medial femoral circumflex that supplies the epiphysis. So these are things that you need to talk about, maybe around anatomy. But what isn't controversial is that we tend to do some sort of, the fixation should be at least 2 screws when we try and fix these, because they're unstable slips, and 1 screw we can cause, if we just fix it with 1 screw, the slip can then continue to lose position in follow-up. So we tend to use 2 screws. There's the trend is to do some mini open at least to try and release the hemarthrosis, because we feel by releasing the hematoma or the hemarthrosis, we may reduce the chance of avascular necrosis. So for the exam, you'll need to say these are rare injuries, high risk of AVN. You're going to manage them in a pediatric center because of the controversies around it. And we will definitely use 2 screws, and we'll try and drain the hematoma. And we may do an open reduction depending on the skill level of the surgeon and their training. Now, when we talk about severe slips, these are slips over 60 degrees. These are also a challenge to treat. They're chronic, and they may have been going on for a long time. And to assess them properly, we often have to do a CT to see whether or not the physis is open, because that will dictate what type of procedure we'll do. Now, a 60-degree slip is quite a severe angle, and even extracapsular osteotomies, the limit of correction is around 60 degrees. So an extracapsular osteotomy will only correct up to 60 degrees, and then we have to think of a open bumpectomy to try and reduce the final bit of the anterior bump. We can use surgical dislocation and subcapsular realignment if the physis is open. Now, when we talk about fixation, and they might tell you about how you do it and the complications related to it. So you'll need to know whether you're going to do it on traction or freehand and using the image intensifier. You need to be able to talk around this procedure. I know I personally do it freehand because I feel that's easiest for me to get a good frog lateral in a stable slip, and then I can just keep the C-arm in the AP position. Joint penetration with a screw can lead to condylosis. If the screw is not centered of the head, it can lead to poor stability and loss of fixation. If the screw comes too posterior, you can risk damaging the deep branch of medial femoral circumflex and increasing your risk of AVN. If it's not anterior in the entry or too low on the lateral entry point, you can increase the risk of developing a fracture. Measuring the slip angle, we tend to do to decide whether or not we should fix the other side. When we measure this, the posterior sloping angle of the contralateral hip, this helps us to predict whether or not we should do a prophylactic pinning. So if you draw a line from the anterior to posterior margins of the physis, a perpendicular line is drawn, and then a line along the axis of the femoral neck. This slip angle, if it's over 14 degrees, anatomically is more associated with a subsequent slip in that hip. And we have a numbers needed to treat of around 1.7. So that's something you can talk about as a decision-making process regarding prophylactic pinning. And remember, there's the bump that's unfortunately can lead to impingement and arthritis later on. When the principles for dealing with intracapsular neck of femur fractures are quite similar. Depending on how much neck we have, we might try and use 2 screws in an extraphyseal manner, whereas in a slipped epiphysis, you have to go across the physis. The aim is to fuse the physis. Now I'm going to move on to femur fractures. And as Tom was alluding, that majority of pediatric trauma comes after school, on a weekend, or in holiday time. So this is when there tends to be registrars that are running the on-call without consultant cover. In summer, people might be on leave. So you need to be able to know how you'll do the emergency management of many of these fractures. The important thing about femur fractures is that they still have quite a high association in the under 3 with non-accidental injury. And the highest risk is in an under 1-year-old, a child that isn't walking with a femur fracture. Now, and the important thing when we think about non-accidental injury, these children often present late. They don't tend to arrive by an ambulance, and the history of the injuries usually does not support the fracture that you're seeing. So they will want you to talk about the management, but remember, most of these children are coming in the evening, so don't forget to talk about pain relief, because you're likely to manage them on the next available trauma list in a planned way. So you need to talk about pain relief, whether or not you're going to use a femoral block, and whether or not you need to use some sort of traction overnight. So there's quite a few guidelines on how to manage femur fractures. And for children on the age of 6 months, we use a Pavlik harness. It's simple to put on, and the fractures heal very well in a Pavlik harness. You might need to talk around about how to put on a Pavlik harness, what the different straps do. And don't forget, you have to say you're going to investigate the child for potential non-accidental injury. Between 6 months and 5 years, we go for an early hip spiker. Remember, once again, under 3, we're worried, is this a non-accidental injury? So discuss that. The decision-making on whether or not we do an early hip spiker or a hip spiker after a period of traction depends on the stability of the fracture. And we look at the amount of shortening that happens on the femoral fracture. If it can shorten more than 3 centimeters, then these are best managed with a short period of traction before putting on a spiker. When we talk about spiker, you can use a single leg spiker, a 1.5 spiker, or both limbs, depending really on the size of the child. And the smaller the child, the more of the contralateral leg you'll need to include. The most important thing is about your position of the leg. How much flexion you have at a hip or knee is dependent on where the fracture is, if it's in the proximal, middle, or distal third. And you also want to do a slight mold to avoid any varus malunion of the femur fracture. A varus malunion has a high risk of refracture because of the eccentric loading of the femur. Our child between the age of 5 and 11, the management is either a flexible intramedullary nail or some sort of open reduction internal fixation, usually with a MIPO bridge plating. We decide what we do depending on the fracture stability. So flexible nails tend to be used for fractures within the diaphysis of the bone. So you can see these dotted lines showing we're looking for a fracture within this kind of central area of the femur. So you can have a entry point which is far enough to give you that stability, that tension. You want to talk about the hoop stresses that you'll develop with pre-bending of the nail. So we look at the fracture location. We look at whether or not the fracture is length stable. So very comminutive fractures will shorten even with a flexible nail, and then you can have failure of your fixation as a result. So the fracture pattern determines how much length stability there is in the femoral fracture and whether or not we can use a flexible nail. So fractures that are around the metaphyseal region are length unstable. We tend to use MEPO plating rather than a flexible nail. Now, the important thing is that there's a weight cutoff for flexible nailing. We say around 50 kilos, we would prefer not to use a flexible nail because we see failure of the flexible nail. We know that we can use a stainless steel nail, which is actually a bit stronger than a titanium nail and still gives you the same hoop stresses. Now, to figure out for a stainless steel nail is equivalent to a titanium nail of 0.5 millimeters bigger diameter. So you can use two smaller stainless steel nails if the isthmus is quite small to get more stability, more strength. The use of end caps are used for length unstable femoral fracture patterns. However, the end caps also cause soft tissue irritation of the knee and can result in early removal of the metalwork because of soft tissue irritation. Now, when we go to a more adolescent, over the age of 11, we're moving on to locked intramedullary nails with trochanteric entry. And there's several different ones on the market. We use the PD nail by Paediatrics because it has a recon screw or a straightforward interlocking screw for a midshaft fracture. The important thing is that we're doing a lateral entry in the trochanteric apophysis, and this avoids damage to that medial circumflex femoral artery. And this minimizes the risk of AVN. Now, when we look at the knee, some of the knee fractures that you'll be asked to talk about is really the distal femur is one of the ones that we would see commonly that might need a urgent treatment. Now, the important thing is that there's the femoral neurovascular bundle is running behind this injury, and there's a high risk of injury to the neurovascular structures with very displaced fractures. So it's important to state that you're going to do a neurovascular assessment. These are usually high energy mechanisms, and they may be associated with ligamentous injuries. So you might do an EUA or required to do an MRI after this injury to help with the management. You can also talk about anatomy of the distal femur physis because of its undulating pattern and that this fact is more concave posteriorly. There's a higher risk of growth disturbance. And this runs to around 50% of these injuries have growth disturbance. So how you manage it, it can be either with cross wires or if there's a large Thurston-Holland fragment, as in this fracture, we can use screws to fix the Thurston-Holland fragment. Next adolescent type injury we tend to see is a avulsion of the anterior tibial tubercle. The tibial tubercle, sorry. This is an ACL avulsion, and it's recommended that an MRI is probably the best way of assessing this injury because you're able to assess the soft tissue structures that can have additional injuries. You might have a meniscal tear at a time. The treatment is a extraphyseal screw or a suture repair. Both are equally equal in terms of fixation strength, and it really depends on the size of fragment whether or not you can use a screw or not. Proximal tibial fractures. the ones we tend to use are tubical avulsion fractures, and these can vary from very minor injuries to much more severe drastic injuries. And the important thing is this is a high energy injury, can be associated with a intra-articular injury to the meniscus and tearing of the meniscus. As this fragment is pulled off with the patella tendon, it tears quite a long soft tissue sleeve of the tib ant muscle and can cause quite a lot of bleeding into the anterior compartment and result in compartment syndrome. So it's quite important to be aware of compartment syndrome in this injury. And we try and anatomically reduce this because it's intra-articular, and we also want to prevent a growth disturbance to proximal tibial epiphysis. So there's a screw here in the epiphysis and one in the metaphysis. You still have to follow these up because you can get late deformity of the proximal tibia with a recurvatum developing. The next most common injury is a patella sleeve avulsion. Once again, it's an injury to the quadriceps mechanism. The child will have an ability to do a straight leg raise. It can be quite subtle with a high riding patella, and you might not see a little sleeve fracture. But remember, this is an intra-articular injury where the cartilage is separated and a small piece of the bone is attached to this. So you once again might need to have an MRI to aid the diagnosis in a young child, but the management is an open reduction internal fixation, usually with a transosseous suture repair. Now, if we move on to tibial fractures, obviously tibial fractures are still very common in children and they remodel very well. But with an isolated tibial fracture, whilst managing in plaster, you have to remember isolated tibial fractures can have this phenomenon of varus drift due to the pull of muscles. So in the lower third, it starts to drift into varus. So often the plaster will need wedging around the 2 to 3 week mark. When both tib and fib are broken, it tends to drift into valgus. So once again, at a 10 to 14 days time, you might have to wedge the plaster to improve your alignment. A couple of eponymous named fractures. In a very young child, you might have a toddler's fracture. This is a common reason for an undiagnosed injury in a limping child. And often you may need to repeat the x-ray in 10 to 14 days to see if there's any callus. Whether or not it needs treatment is still debated. Many can just be given no immobilization. Some children need a small walking boot or temporary plaster for 2 to 4 weeks. Cosen's fractures are fractures of the proximal tibia, which have this phenomenon of valgus overgrowth. So as it heals, the leg then develops a valgus deformity later on. When we follow up Cosen's fractures, we know that this valgus tends to correct in the majority of children within 2 years. If it doesn't, we can simply manage it with a guided growth procedure where we put something called an 8 plate or a temporary epiphysiodesis plate on the medial side to allow a lateral side to keep growing to recorrect the valgus. Now, when we move down to ankle fractures, you'll see from this this graph that depending on the age of the child, we'll see different Salter-Harris fractures of the ankle. So the younger child, we tend to see this type 1 and type 2 fractures, sometimes the type 4. As they become more adolescent, you then see the triplane fractures. Now, the reason behind this is how the distal tibial epiphysis fuses and the physis fuses. So it starts just over the medial malleolus. It starts in a central area there, and then the medial malleolus fuses around 13. Then it progresses towards the lateral side, and the last area to fuse is the Tibial fracture area. So a Tibial fracture tends to be in a slightly older adolescence because it's the last area to fuse in the distal tibial physis. But depending on the age of the child, the stage of fascial closure, we get different triplane fracture patterns. So the triplane fracture pattern is just because part of the physis is fused, it goes through the weakest part, which is the unfused physis. So the younger you are, the more chance of getting more fragments. The older you are, it tends to be just a telau. Now, you might be asked about the Laug-Hansen classification for adult ankle fractures, but also it's the same for children's fractures, and Diaz described it. And remember, it's the first thing, supination is position of the foot, and the next term is which direction the foot moved, or the limb moved. So supination inversion, so the foot was supinated and then there was an inversion force. And you tend to get these Salter-Harris 4 fractures, and these can actually have quite a high rate of growth disturbance. The most common type we see is a supination plantarflexion, where you have this fascial fracture, often with a posterior Thurston Holland and a little bit of displacement. It's very low risk of any fascial closure here. When you go to the supination external rotation, you'll see this fracture pattern where it starts off quite low on the lateral distal tibia and exits higher up. So looking at the angle of this fracture pattern will help you to know if it's a supination external rotation or pronation external rotation, which tends to have the Thurston Holland on the lateral side, where the Thurston Holland's on the medial side. And I've shown you the rates of fascial disturbances with these injuries. But the most common type is we see this supination plantarflexion injury, and you'll see there's a gapping at the front of the anterior aspect of the tibia, and this is due to the infolding of the periosteum. So if you're unable to reduce this closed, you don't force it, you often need to do a small mini-open reduction and fish out the periosteum and then reduce it. You may need to put a single wire to hold it, or just a plaster to keep it stable. If there's a large Thurston Holland fragment, you might use a screw to fix it. So foot injuries, majority of foot injuries heal very well in children. And most heal just with some immobilization and walking boot. I guess the Jones fracture, remember, is potentially might take a bit longer to heal in a child. But so we may just immobilize the foot between 4 to 6 weeks. But it's not the same as an adult fracture. There's much less risk of non-union. And if it does become a non-union, it's quite easily managed with screw fixation. The only other foot fracture to remember is the femoral fracture, which is an avulsion of the nail bed out of the nail fold associated with a Salter-Harris fracture of the distal phalanx. So it's important to know that this is an open fracture and we need to do a nail bed repair and treat the child with some antibiotics to prevent any infection. Okay, thank you very much, guys. That's the end.